Thank you to the SGA for the invitation. I was asked to talk about updates in the management of autoimmune liver disease. I have so much to cover and I have 20 minutes, so we'll dive into it. Autoimmune hepatitis is an inflammatory disease of the liver. The inflammation is mediated by the immune system, but it has no clear etiology. The disease was first described in the 1950s. It is defined by characteristic histological features, elevation in the aminotransferase and immunoglobulin G, as well as the presence of circulating autoantibodies. And of course, you have to rule out other conditions that might present in a similar fashion. We know that the presentation of autoimmune hepatitis is variable. It can range from mild asymptomatic disease, and the only evidence is just elevation in the liver enzymes, to acute liver failure or even end-stage liver disease with portal hypertensive complications. The minute you find or you see one autoimmune condition, look for other immune-mediated diseases that affect other systems. So it is now recommended to look for other autoimmune conditions like celiac and autoimmune thyroid diseases. Autoimmune hepatitis can coexist and overlap with other immune-mediated liver conditions like PBC or PSC. And it can also coexist with other hepatic pathologies like MASLD or viral hepatitis. We know that autoimmune hepatitis is classified into two main types based on the serology profile. Type 1, where you see ANA and SMA positivity, and type 2, if those are absent or negative and you have anti-liver kidney microsomal antibody type 1. 20% of autoimmune hepatitis cases, they are ANA, SMA, and LKMA1 negative, and it's in that situation that you have to look for other autoantibodies, like the anti-soluble liver antigen and the atypical Pianka in type 1, or the anti-liver cytosol antibodies and the LKMA3 in type 2. We know that patients who present with severe autoimmune hepatitis or acute liver failure, they tend to have a seronegative disease. The new thing, as we will see in the upcoming slide, is now they allow the use of ELISA to detect some of these autoantibodies. So we know the International Autoimmune Hepatitis Group, they came up with a revised diagnostic score or criteria in the 1990s. Then the simplified autoimmune hepatitis score was released in 2008, and it's more specific and less sensitive compared with the revised diagnostic criteria. And finally, in 2021, it was edited to allow the use of ELISA to detect those autoantibodies. The treatment, unfortunately, autoimmune hepatitis is one of those diseases like IBD. It is characterized by intermittent relapses and remission. Some of the risk factors that are associated with increased risk for relapse is shorter duration before reaching remission, high ALT and IgG, as well as the presence of inflammatory infiltration histology prior to the withdrawal of immune suppression. We know that FibroScan is an excellent tool to stage fibrosis, but in patients with autoimmune hepatitis, I guess you need to wait for some time till the inflammation settles down. Then FibroScan can be used to stage fibrosis. Iron-corrected T1 is a novel method of reading MRI images. The unique thing about this new modality is its ability to detect inflammation even in patients with liver enzymes that are within normal limits. We know this technology being used in many of the clinical trials for MASLD, and I guess in the near future it can help us decide when to withdraw immune suppression in patients with autoimmune hepatitis. Again, the non-invasive test in the staging in staging fibrosis in patients with autoimmune hepatitis. We know that the liver, the biochemical or the blood-based scoring system do not perform quite as well like elastography. We know patients with autoimmune hepatitis, if they do not get treated, they have reduced survival compared with those who undergo treatment. Up to this point, the first line of treatment is steroid monotherapy versus steroid combined with azathioprine or Imuran. We have multiple studies, especially from the 90s, that confirmed the positive impact on clinical, biochemical, and histological features of autoimmune hepatitis, as well as the improvement in survival. In 2010, there was a study by Mann et al. That was published in Gastroenterology, which hinted at the superiority of budesonide compared with prednisone or prednisolone. But we know that from real-world studies and from a retrospective study that was published in 2023, that actually the reverse is true. I guess when it comes to the use of monotherapy versus combination therapy, you have to look at the comorbidities of your patient and their protoplasm to decide on which way to go. This study was looking at comparing MMF with prednisone or prednisolone versus azathioprine and prednisolone. It was conducted in Belgium and the Netherlands, and the primary outcome was the percentage of patients with normalization of ALT and IgG at the 6-month mark. And as you can see, MMF was superior, with prednisolone was superior to the combination, or the combination we know of azathioprine and prednisolone, at achieving the primary outcome with less side effects. But I guess this slide begs the question, do we have enough information to replace MMF with azathioprine? And can we use MMF in a disease whose patients are predominantly female in their childbearing potential? I guess we need to wait for more information, and I don't think it's going to replace the combination of azathioprine and prednisolone in the near future. And again, one of the things that we need to emphasize is the standardization of language and terminology we use to describe the response of patients to treatment. If you have someone with less than 50% reduction in ALT and AST, as well as in a month, this is the definition of no response or non-response. If you have someone who achieved complete normalization of ALT and IgG at the 6-month mark, this is what defines complete biochemical response. Other than that, it will be called insufficient response. And again, complete remission is when you have really no histological activity on biopsy. Again, unfortunately, around 10% of the patients will not respond to your first-line treatment. And in that situation, we do have other options like MMF and CNI, mainly tacrolimus, as well as a bunch of biologics. We know from a meta-analysis from 2019 that actually MMF is an excellent second-line option, and the biochemical response in patients who were intolerant to azathioprine is in the neighborhood of 80%, while those who did not respond to azathioprine in the first place is around 32%, but the net response is in around 60%. Tacrolimus can be used, and again, with the CNI level between 1 to 10. Of course, there were some studies that looked at CNI level more than 10, but we know from experience that if the CNI level goes above 10, you will encounter many side effects like increased risk of infection as well as renal toxicity. But tacrolimus as a second-line option, in addition to steroids, can achieve partial or complete biochemical response up to 94%. Rituximab and infliximab, of course, they can be used in the treatment of autoimmune hepatitis, but we know that infliximab itself can be associated with an autoimmune hepatitis-like form of drug-induced liver injury. Liver transplantation from King Faisal Hospital, and in a study that was published in 2021, represented around 15% of the indications for liver transplant. But we know that autoimmune hepatitis as an entity represents around 5% of the indication for liver transplantation in the States and Europe. Excellent 1- and 5-year graft and patient survival, but we know the risk of recurrence is high, and we know that we encounter more rejection, steroid resistant as well as chronic rejection in this cohort of patients. Moving on into primary biliary cholangitis, it's an immune-mediated cholestatic conditions. It is defined by, if you have 2 out of the following 3 criteria, you can diagnose patients with PBC. Histological evidence of biliary damage with evidence of cholestasis, as well as the presence of AMA or PBC-specific ANA. We know the majority of patients with PBC are female, but the proportion of males being diagnosed with the disease is on the rise. Most of the patients are asymptomatic, and once they reach end stage of a disease, the picture or the clinical picture will be dominated by symptoms of portal hypertensive complications. But at an earlier stage, the main symptom is, if they have symptom, is pruritus and fatigue. I guess this is the current paradigm of PBC treatment. Diagnose them, start them on Orsodiol, and then wait for a year and then monitor their response. Your response and what you want them to have is ALP reduction. If they do not have, or if they have inadequate response, then you can use obeticholic acid or fibrates. These are some of the prognostic tools we use in PBC. These are some of the new medications that will change and will lead to a major shift in the PBC treatment paradigm. Elafibranor, Seladelpar, Saroglitazar, and as you notice, almost all of these medications, they work through the peroxisome proliferator activated receptors, whether that be delta, alpha and delta, or even alpha and gamma. These are some of the obstacles we face in the management and the treatment of PBC. How many of the patients will not or will have inadequate response to Orsodiol, and it's around 40%. And also we need to do a better job at managing some of the symptoms and of PBC like pruritus and their impact on the patient's quality of life. Many of the medications and the options we have cannot be used in patients with decompensated cirrhosis. So can we use some of the new medications? I guess we need to wait for some of the new clinical trials that try to address this question. This is the ELATIVE trial. It's a phase 3 RCT. It compared elafibranor with placebo, and their definition of biochemical response is ALP less than 1.67, and the percentage of ALP or 15% reduction in ALP. And also they looked at normalization of ALP as a secondary objective. As you can see at the end of the study at week 52, elafibranor was way better than placebo at achieving the biochemical response. Unfortunately, it had no impact on pruritus. Moving on to the second medication, Seladelpar, in the response trial, which was a phase 3 RCT that compared the PAPAR delta agonist Seladelpar with placebo. And as you can see at the end of the study, Seladelpar was better than placebo at achieving biochemical response, 61.7% compared to 20%. And the good thing is Seladelpar was good at improving pruritus and etching in those patients. Ursodeoxycholic acid, we know that based on retrospective studies and meta-analysis, it has good impact on solid endpoints like survival. From some real-world studies, we know that obeticholic acid is associated with improved transplant-free survival. We are yet to see the positive impact of PAPAR agonists on these solid endpoints like survival and the occurrence of hepatic decompensation, as well as transplant-free survival. Steroids, and when I say steroids, I mainly mean budesonide, was associated or was used in the treatment of PBC. And in the small RCTs that assist budesonide, it was associated with improvement in biochemistry, histology, immunoglobulin M levels. But we have to remember that the treatment of those patients is lifelong. And their exposure to steroid will be more, which will put them at risk of all the complications we know. There were some retrospective studies that suggested increased risk of PBC recurrence with tacrolimus compared with CNI, but we know from recent studies that actually there is no difference in graft and patient survival between the two CNIs. MMF use in addition to CNI was associated with improved outcomes, and we know we'd like to keep those patients on Orsodiol to decrease the chances, since it might decrease the chances of PBC recurrence. Actually, this is the old presentation. What I wanted to say in the last slide, the European Medical Agency has revoked the approval for obeticholic acid, and Yesterday, there was a drug safety communication issued by the FDA. Basically, obeticholic acid can lead to serious liver injury even in patients without evidence of cirrhosis or clinically significant portal hypertensive complications. So I think in the near future, the PAPAR agonists and medications working through other mechanisms of action will be replacing obeticholic acid as a second-line option. Moving on to the third and last immune-mediated liver disease that I'll be talking about, PSC. We know it's a fibroinflammatory condition of the liver. Eventually, it leads to stricturing and liver fibrosis and cirrhosis. The other unfortunate thing about this disease is the increased incidence of colorectal as well as hepatobiliary malignancies. It is associated with IBD, since 75% of patients with PSC, they have IBD. 10% of the patients, they have small duct PSC where the cholangiogram is completely normal. It's a rare disease, but again, the same rule. If you see one autoimmune disease, look for other immune-mediated conditions. Most patients are asymptomatic at the diagnosis, and if they have symptoms like PBC, it's going to be fatigue and pruritus. If they reach end-stage liver disease and significant fibrosis or cirrhosis, the picture is going to be mainly a picture of portal hypertensive complications. We know that the diagnosis is with RCP. We know that high ALP, bilirubin, and elevated IgG4 level portend poor prognosis in patients with PSC. To make the diagnosis of PSC or primary sclerosing cholangitis, you need to rule out other conditions that might look clinically or radiologically like PSC. And this is an extensive but not exhaustive list of conditions that might look like PSC. So if you rule out these conditions, you are left with PSC. Again, we do liver biopsy if you think they have small duct PSC or if you think there is something else going on with the patient besides PSC, like PSC and autoimmune hepatitis overlap syndrome. High LP is associated with worse prognosis. Again, to stage fibrosis, we can use transient elastography or magnetic resonance elastography. There are multiple clinical and biochemical-based prognostic scores, as well as radiological or MRI-based scores that estimate the overall survival, transplant-free survival, or the chances of your patient having a decompensated disease. These are some of the scores, like the Amsterdam-Oxford score, UK PSC. And this is an example of one of the MRI-based prognostic scores. Also, ursodeoxycholic acid, unfortunately, or ursodeoxycholic acid or ursodiol did not have any significant impact on solid endpoints like survival, histological activity, but we know it can lead to improvement in the biochemical picture of the disease, and we know if ALP normalizes or there is reduction in ALP, it is associated with good prognosis. I guess one of the main questions, does control of IBD lead to better outcomes in PSC patients? There was a recent meta-analysis that showed a good impact of gut microbiome modulation using antibiotics and mainly vancomycin on ALP, bilirubin, and the Mayo risk score. Dominant strictures are associated with worse prognosis. So malignancy needs to be ruled out and they need to be treated. 40% of patients with PSC, they will experience bacterial cholangitis in their lifetime. And I guess treatment should be initiated with antibiotics, hydration, and endoscopic intervention. And if there is no improvement to your intervention, think about fungal infection and add antifungals. Lifetime risk of cholangiocarcinoma and gallbladder cancers are around 20 and 3.5% respectively. The surveillance, the study around surveillance and the impact of surveillance on the natural prognosis of PSC, the results are conflicting, but there was a recent multi-center study from Sweden that showed improved survival and transplant-free survival in patients with PSC who undergo regular surveillance with MRI. Colonoscopy is recommended to rule out colorectal malignancy, and patients with PSC cirrhosis, they should undergo ultrasounds to look for HCC. The usual indication for PSC are portal hypertensive complications, synthetic dysfunctions, but there are unique indications, as we know, and some of these unique indications are the intractable pleuritis, recurrent bacterial cholangitis, as well as cholangiocarcinoma, whether that be hilar cholangiocarcinoma, and now we see more and more about transplanting patients with early intrahepatic cholangiocarcinoma. Again, excellent patient and graft survival in patients with PSC, but the chances of recurrence are high, around 30%. These are some of the new medications that are being studied in the treatment of PSC. Vancomycin, if you look at the lower half of the table, vancomycin, statins, bezafibrate, and nororthodoxycholic acid are in phase 3. Hopefully we will see some positive results with one of those medications, even though all the medications that have been studied so far did not pan out. I guess I will conclude my presentations with a slide about the treatment of cholestatic pleuritis. We know that in the upper half of the table, these are the medications that we currently use to treat pleuritis and itching in patients with cholestatic liver diseases. Most of the evidence supporting the use of these medications come from clinical trials with small sample size, with a high chance of bias, and almost all of them were of short duration. But I guess the new kid on the block is the IBAT inhibitors. So I think the IBAT inhibitors and the fibrates like bezafibrates will represent the cornerstone.
Time, Dr. Fahad. Time is finished.
Of pleuritis management. Thank you so much.